Get past the jerk. Decoding nystagmus, which is a repetitive involuntary movement of the eyes. Evaluation of nystagmus might seem like a Herculean task even for experienced ophthalmologists. So let's get the terminologies right. A slow drift followed by a rapid saccade is a jerk nystagmus, whereas a sinusoidal oscillation with slow phase without a saccade is a pendular nystagmus. Nystagmus occurring in one eye is unilateral, whereas in both eyes if present, it's a bilateral nystagmus. Nystagmus occurring when one eye is covered is latent, where it beats towards the fixing eye. However, when present all the time, it is a manifest nystagmus. Nystagmus symmetric in direction, amplitude and rate between the two eyes is conjugate, and if asymmetric between the two eyes, it is a disconjugate. Amplitude is defined in terms of excursion as fine, medium and coarse. Frequency is number of to and fro movements within a second. Both of them together decide the intensity, and that's minimum in the null zone. Like in this patient in the right gaze, jerk nystagmus is defined in terms of the direction of the fast phase, whereas pendular nystagmus can be either horizontal or vertical. Pendular nystagmus is not characterized by right, left, up and down, as there is no fast phase, but jerk could be right, left, upbeating or downbeating. The nystagmus is evaluated along these lines. In this video, we will provide a systematic approach to simplify its evaluation. It's either physiological or non-physiological. Physiological includes optokinetic, vestibular or endpoint, whereas non-physiological could be congenital or acquired. In congenital, it is congenital latent or latent manifest or spasmus nutans, whereas acquired could be any of these from gaze-evoked, vestibular, upbeat, downbeat, seesaw or periodic alternating. Let's understand the types of nystagmus. These are the physiological. Optokinetic is a jerk nystagmus in which the slow phase follows the target, whereas the fast phase is the eye when it fixates on the new target. Vestibular, physiological one, is an altered input from the vestibular nucleus, a rotatory nystagmus due to stimulation of the vestibular labyrinth or the nerve due to rotation. The congenital nystagmus is horizontal, but also could be vertical or elliptical. It's jerky or could be pendular, and 90% associated with visual sensory disorder. Nystagmus evaluation needs a thorough history taking, as mentioned, followed by a detailed ocular examination that includes binocular vision, then monocular vision with fogging, which should be done in primary position and with the abnormal head posture, after giving full optical correction for the smallest font that can be seen for distance and near. The anterior segment should be thoroughly evaluated for any abnormalities as mentioned, and also a detailed posterior segment evaluation. Now, absence of any ocular problem rules out a sensory nystagmus, and then we are looking at a congenital motor. So what are the management options? First and foremost, the objective is to improve the visual acuity by diminishing the amplitude and frequency, transfer the nystagmus blocking position to a frontal position, improve the abnormal head posture, and correct the strabismus if any. For that, we can either use prisms, bilateral base out prism stimulating conversions. This can correct a small head posture. Then contact lenses, which help to increase the foveation time, and tinted can be given in albinism. Now, surgical management is basically reserved for those with an abnormal head posture, and the principle is to shift the null zone to the primary position and improve vision, to reduce the amplitude by weakening the muscle force on the recti and increase foveation time by tenotomy. Now, for horizontal face turn, the Kestenbaum's procedure, where you resect all the 4 recti as shown, along with augmentation. You can also use a Parkes modification, the 5-6-7-8 rule, but it doesn't correct more than 10 to 15 degree. Anderson is bilateral recessions. For example, null zone to left, weaken the levoverters. Now, nystagmus along with squint, like in this patient with left face turn, having left esotropia, the nystagmus surgery is done in the right eye, and the left eye, the strabismus surgery is done, and you can see the face turn corrected and the squint as well. For a vertical head posture, that is chin up or chin down, you tackle the vertical recti. So, surgery designed to improve vision are artificial diversions using the bimedial recession, the unilateral recess resect, or a 4-muscle retroequatorial recession, tackling the MR and the LR. Coming back to the other forms of congenital non-physiological nystagmus, spasmus nutans, which is a triad of head turn, head nodding and nystagmus, as you can see in this child, with monocular and asymmetrical shimmering, typically develops in the first year resolves by 10 years, but need to rule out CNS tumor, that is a glioma. Now coming to the acquired vestibular nystagmus, it could be central or peripheral related to the vestibular organ and the nerve. In case of the central one, we are looking at unidirectional or multidirectional, and peripheral, which is the unidirectional, the fast phase towards the normal ear. Central can be suppressed with visual fixation and has brainstem or cerebellar signs, but peripheral will not be suppressed and has other findings. Downbeat nystagmus is a jerky nystagmus with an updrift followed by corrective downward saccade. Look at this child having a downbeat nystagmus. Upbeat, on the other hand, has a fast phase beating upwards. In this child, note the upbeat nystagmus. Seesaw nystagmus is an intorsion and elevation of one eye and a simultaneous extorsion and depression of the other eye. Note the seesaw in this patient. Periodic alternating nystagmus is a horizontal nystagmus that predictably oscillates. A single concentrated effort of observation for at least 3 minutes is needed. Note the right beating here changes to a left beating. Initially a left beating, eventually shifts to a right beating. So watch him for 3 minutes to detect if this changes. Torsional nystagmus is a rotatory movement of the globe about its antero-posterior axis. As the seen, the upper pole beats away from the site of the lesion. Gaze evoked, on the other hand, is the most common nystagmus when it's present only in a particular gaze and it's associated with cerebellar signs. Internuclear ophthalmoplegia is a disorder of the conjugate lateral gaze affecting the eye, shows impairment of adduction. When attempt is made to gaze in the opposite direction, the contralateral eye shows horizontal nystagmus. Left INO with an adduction of -4 and an abduction nystagmus. Convergence retraction nystagmus is a part of the dorsal midbrain syndrome with an upgaze palsy, defective convergence, eyelid retraction, and a light near dissociation. Note the conversion and retraction on attempted upgaze. The horizontal movements are perfectly fine, but the patient cannot look up. This is a classical convergence retraction nystagmus. So let's understand the pathology behind each of these. Dissociated nystagmus like an INO, expect that MLF. Downbeat nystagmus, cervicomedullary junction. Upbeat nystagmus, posterior fossa. Seesaw nystagmus, paracellular, monocular childhood nystagmus, anterior visual pathway. Periodic alternating nystagmus, posterior fossa. Convergence retraction nystagmus, dorsal midbrain. Drugs are known to inhibit the excitatory neurotransmitters in the CNS. Commonly being used are baclofen, gabapentin, memantine, and acetazolamide. Botulinum toxin A alleviates symptoms in acquired nystagmus, that is the oscillopsia, to improve foveation time. 2.5 to 5 units can be given in all 4 horizontal muscles, or a single dose of 25 to 40 units in the retrobulbar space. So in summary, evaluation of nystagmus is multidisciplinary. Appropriately evaluate any neurological nystagmus. Try to improve the quality of life with drugs and optical devices and even surgical procedures to correct any abnormal face turn. No single procedure has shown to be consistently predictive of success, but this does not mean we cannot try. Thank you.